Welcome to the sixth and final webinar of the Telehealth Echo Project series. These events have been brought to you by the American Academy of Pediatrics, California, Chapter 2, in collaboration with the San Bernardino County Medical Society and the California Medical Association. This telehealth project was made possible by a grant from the American Academy of Pediatrics, our national organization. As a reminder, our session is structured in such a way that the whole thing will last 60 minutes, with the didactic portion during the first 30 minutes, followed by a case presentation and Q&A. Today's topic is telehealth after COVID-19, presented by David Ford. David Ford has been the MVP of the Telehealth Project series. He has been a great advocate for telehealth, not only for us, but obviously for the CMA. And we are so thankful to have David presenting to our group. David Ford is the Vice President of Health Information Technology for the CMA, the California Medical Association. He develops CMA's thought leadership in all aspects of IT EHRs, health information exchange, and telehealth. He is a nationally recognized expert on the transition to electronic health records and health information exchange. Prior to joining CMA, David was the executive director of Calypso, the largest federally designated regional extension center for health information technology in the nation. David started his career as an employee of the California State Legislature. He served most recently as the chief of staff to then Assembly member Ted Lieu, now a member of Congress. David holds a BA in political science from the American University of Washington, D.C. Please welcome David Ford.
Thank you for the introduction, Tomas. Very kind. Happy April, everyone. Glad to be with you again. I was asked coming here today to talk about telehealth post-COVID, and I will say up front, it is a topic that is very much in flux. I wish I could tell you today this is exactly what's going to happen as the pandemic abates and as the vaccine rolls out, as the economy opens back up. Here's what's going to happen in telehealth. But we don't know yet. So I do want to put that right up front. There's a lot of moving pieces right now. There's a lot of things in flux. It's all going to work out over the next couple of months. And what I'm hoping to do today is really to just give you some things to look for, give you a sense of where things are right now, and some big, some important milestones that we're going to hit that you can watch out for as this all shakes out. First, if you've seen my other presentations, you've seen the slide before. I have to make the quick disclaimer: I'm not a lawyer. Nothing I'm giving you is legal advice. The lawyers get mad if I don't do that, so I did it. As we talk about telehealth in, post the pandemic, I think it actually helps to set the stage if we look back a little bit over what's happened over the last now 13, 14 months. And I know Medicare doesn't play a big role in pediatric practices, but I think as we all know, Medicare tends to set the stage for other payers. And so it really was a really big and important milestone last year when Medicare expanded all of their telehealth payment parity rules. They expanded the number of services that Medicare would pay by telehealth. For the first time, they paid full payment parity for audio only or telephone telehealth, which previously in Medicare had been a check-in and paid at a much lower rate. And put a pin in that because I'm going to come back to it later. It's important for something that's happening in Sacramento. And then importantly, what Medicare also did was they waived what's termed the originating site rules, which allowed physicians and patients to be at home doing telehealth. They didn't have to be in a facility. They also lifted restrictions that previously existed in Medicare that really limited telehealth to patients in very rural areas. Then quick on their heels, the state came down with a whole series of payment parity rules. Department of Healthcare Services, Department of Managed Healthcare, the Department of Insurance, even the Division of Workers' Compensation, 1, 2, 3, 4 all came down with similar payment parity rules that were very much mirrored on the Medicare rules, but also took some stuff that was already going to happen in state law and moved it up to the enforcement into last year. And what we saw with all these payment parity, rules that were put in place and all these waivers of these rules was exactly what you'd expect to see, which was that telehealth exploded. CMA did a survey back in October of 2020, which crazy now 5 months ago. And it was actually a larger survey about basically the general effects of the pandemic on physician practices. But we asked a series of questions specifically about telehealth, and we found some things like 64% of physicians who answered the survey had implemented telehealth during the pandemic. About another 20% had already implemented telehealth. So when you put those together, telehealth was now at about 85% of physicians who are using it at some portion of their practice. On average, telehealth visits increased 57% during the period from March to October. And then importantly, almost 70% of physicians reported that their patient experience with telehealth was either good or very good. So what we saw is, we put this all together, physicians rolled out telehealth very fast. There was this huge increase, and really importantly, everyone kind of seems to like it. And I think all the time, and forgive me if I told you about this in one of my previous webinars, but I think all the time, if you sort of know the landscape of Southern California, which you probably do, I talked to one physician whose practice was in Temecula, and some of his patients drove to his practice from Hemet. Those patients were really happy when that provider rolled out telehealth and they didn't have to make that drive to come down and see him. So, I think there's very much the sense that telehealth is and should be here to stay. And so for CMA, that's really our focus right now. There's work going on both here in Sacramento, where I'm sitting right now, and back in Washington, D.C., to really try to cement these gains that were made during the pandemic, but also implement lessons that we've learned in the last, 10 to 13 months to really ensure that telehealth, as it continues to roll out, is rolled out the right way. That's important to some work that CMA is doing at the moment. So, because it's probably more relevant and the part I know better, let's start with what's going on here in Sacramento. So first and importantly, if you're not aware, because it kind of got lost in the pandemic, we do, as of January 1 in California, have a telehealth payment parity law that covers commercial payers. Now, importantly, there was a restriction put in the bill. The bill was actually signed by Governor Newsom in 2019, and there was a 1-year delay. It took effect officially January 1 of this year. Now, it only applies to contracts that are issued or renewed after January 1st, 2021. So any new contracts, any renewed contracts you get starting this year from commercial payers must pay telehealth at parity with in-person visits. This law does not apply to Medi-Cal managed care. That was one of the difficult amendments that CMA had to take when we were moving this bill through the legislature a couple of years ago. Of course, if Medi-Cal managed care is included, that creates state cost. So that was excluded. We're trying to fix that now, but for many of your commercial patients, telehealth will be paid at parity, regardless of what happens with the public health emergency. But to fill in some of those gaps that were left by Assembly Bill 744, there is a new piece of legislation that is being discussed in Sacramento right now. Assembly Bill, or AB 32, actually has the same author as AB 744, Assemblywoman Aguiar Curry. She has really become the champion in California for telehealth. This was actually one of the first bills that was introduced in this session. And it makes payment parity apply to all commercial contracts, so not just the new or renewed ones. It will enforce payment parity on Medi-Cal managed care. That's important as well. And also clarifies in law that telehealth includes the telephone. Now that's a kind of a funky one because as it currently sits in California law, the definition of telehealth includes the telephone because it doesn't say that it doesn't. And I know that's a little weird, but the definition of telehealth in California law actually used to have a provision that specifically excluded phone-only visits from the definition of telehealth. Some years ago, there was an assemblyman from a very rural community who carried a law that struck that exclusion from California law, but it continues to be a little bit of a gray area because the law doesn't exclude telephone anymore, but also doesn't affirmatively say that telephone is included. So we're trying to just finally fix this problem, resolve it, include telephone, so it's not a question. To support all this work, this isn't, I imagine probably for many of you probably isn't your focus, but I think it is really, really important. What's up here on the screen right now is just a sampling of bills that have to do with access to broadband. Obviously, this has been a huge topic in the legislature right now because it not only affects telehealth, it affects health information exchange, but also affects a whole bunch of things outside of healthcare, like remote work, distance learning. You know, we've learned a lot in this country over the last year or so about how challenged our broadband infrastructure really is. So I took the sampling of a few bills you can watch here. There is also very likely to be a conversation in the state budget around trying to coming down from the FCC to support broadband. I think that is another issue that really bears watching in the months to come. So this one I imagine is very important to you because we're in a state where I think, what is it, half or 60% of children in the state are covered by the Medi-Cal program. I think really important to know, if you do not already, that there is a proposal that the administration has put out specifically about the future of telehealth in the Medi-Cal program. Sure. One part of it that CMA really likes is that the administration has proposed to extend payment parity rules to Medi-Cal managed care. So obviously, the administration put a very important restriction on that parity rule in their proposal, which is that it only applies to synchronous video conference telehealth. So the administration is proposing to create a separate and presumably lower fee schedule for phone-only asynchronous telehealth and remote patient monitoring. and it's not just CMA. We're working with a big coalition of folks, including the Primary Care Association, who represents the federally qualified health centers, the Hospital Association, Planned Parenthood, and others who are all very concerned about this proposal. There was an initial proposal that the administration put out in February. I think they've heard from a lot of folks who are not happy about this. I mentioned earlier to kind of put a pin in what Medicare said about use of the phone. It's important because what we believe is happening is that Medi-Cal is trying to pick up the pre-pandemic Medicare rules for use of the telephone, where you can get paid for use of the telephone, but it's considered a check-in, not a visit. My understanding is that for most physicians, Medicare for that check-in on the phone pays about $10, because it's presumed that it's just a couple minutes on the phone with the patient saying, "Hey, I saw you last week. Are you taking your meds? How are you doing?" And not a full office visit. So we do, from an advocacy place, CMA does not want to see Medi-Cal adopt that system. We don't believe that's a good system. But there really does appear to be a lot of concern in Sacramento specifically about the phone. So more to come on that one. So there are some key dates that you can watch for when we might have some more solid information. Two of these obviously have already passed. The governor introduced his budget proposal in January. The bill introduction deadline was February 19th, so about a month and a half ago. Very likely that a lot of what happens in Sacramento, especially around telehealth, will get sorted out in the state budget. So in case you're not aware, the last day for the governor to sign the state budget is June 30th. So hopefully we'll have some more, again, that's another date where we might have some more solid information about what's going to happen. And then September 10th, that's the last day of the legislative session for this year. So the fate of Assembly Bill 32, good, bad, or indifferent, we should know by September. So, and then Washington, D.C. Now, again, I know I'm talking to a bunch of pediatricians. I'm going to talk a lot about Medicare here. But again, we do believe a lot of folks are trying to follow Medicare's lead on this. They did at the beginning of the pandemic. And I think a lot of folks are looking towards Medicare to see what will happen at the end of the pandemic as well, and what Medicare is going to keep in place and what they aren't. There's a whole lot of moving pieces, obviously, since the pandemic started. You may have heard we have a new president. We also have a new Secretary of Health and Human Services. Obviously, we're very excited about him. He's a Californian. He was a congressman. He was our Attorney General. So we're very excited about that. But then really, really importantly, I mean, the biggest thing that, probably the biggest and most important thing to pay attention is the federal declaration of the public health emergency. And right now, that public health emergency is in effect until April 21st. It was actually one of the last things that the previous administration did on their way out the door was extend the federal health emergency. It can only be extended 90 days at a time. So right now it's in effect until April 21st. I would bet everything I have that it will be extended sometime before then in the next couple of weeks. So as long as that federal public health emergency is in place, on the federal level, at least, nothing changes. Plus the fact that the state declaration of a public health emergency will likely continue along with the federal one. So I would watch the next couple of weeks. I guarantee you 100% it will be renewed. So again, the importance of that from a Medicare level is that everything that Medicare put in place for the public health emergency stays in place as long as the public health emergency stays in place. And much like we have in Sacramento, the real question we're looking at is what happens when it ends. And one of the important things to watch is that Medicare, unlike, very, very similar to what's happening here in Sacramento, on the federal level, CMS can't just wave a magic wand and keep all of everything they put in place under the public health emergency in place. Many of these things, if they're going to be kept in place outside of the PHE, they would take congressional action. So we do expect there will be congressional action. The question is how much and how fast. There were a couple bills introduced. Don't write down these bill numbers because they're actually from the previous Congress, but I'm using them as an example. There was legislation in the previous Congress to make permanent the originating site waiver, retain all the additional services that Medicare covers by telehealth, allow FQHCs and RHCs to provide telehealth. While these didn't move in the previous Congress because election year politics and all of that, again, I feel very, very confident similar legislation will start to move in this Congress. I think we had hoped it would get wrapped up into one of the COVID relief packages. Bits and pieces of it have, but there still needs to be one sort of big congressional discussion about telehealth that we think is coming. And then one thing that I think has not gotten enough attention, but is tied to the public health emergency and does, whether you never see a Medicare patient or not, I guess I should have said that backwards. Whether you do or don't see Medicare patients at all, this actually does potentially affect your practice, which was the OCR notice of enforcement discretion. And in the early days of the pandemic, when there was just a lot of go around telehealth, the Office of Civil Rights in HHS, which enforces HIPAA, came down with an opinion and basically said, okay, for the purpose, for the time covered by the public health emergency, we are going to allow providers to use technology for telehealth that otherwise would not be considered HIPAA compliant. So that includes FaceTime, Skype, Google Hangouts, Zoom. I should say for Skype, Google Hangouts, and Zoom, talking about the basic versions of those, not the healthcare version, because all three of those do actually have HIPAA compliant versions. But as I say, all of those under normal rules would not be considered HIPAA compliant. But OCR basically came down with an opinion and said, for the time covered by this emergency, we're going to look the other way and not enforce those HIPAA rules around those technologies. Now, if anyone who's listening to this presentation is using one of those platforms, just know I don't think anyone believes that that will be kept in place at the end of the federal public health emergency. So I know, for example, I talked to a lot of physicians who are using FaceTime on their iPhones, and it's great. FaceTime is not HIPAA compliant. You just need to know that. And with that, when that public health emergency ends, this notice of enforcement discretion will go down with it. So just please be aware of that. And so, if you're using one of those platforms, if you're using one of the basic ones, you have two choices, which is either to upgrade to the HIPAA compliant version. So Zoom, if you're using the basic version of Zoom for healthcare, a little more expensive, but is HIPAA compliant. Or of course, you can select a different technology altogether. That link that will come in this slide deck is to a shameless plug, is to a webinar we did CMA did a few months ago about selecting the right platform if you do need to go back and find a new one. So I am happy to take questions. I did want to make one more just shameless plug. A week from today, I am doing my final installation in my 12-part telehealth webinar series under the CMA banner, which is our telehealth town hall. Very minimal presentation. The idea is just to have an open the phone lines and allow everyone to bring all of their questions about telehealth to the experts at CMA. So I opened all, even if you're not a CMA member. So hope you will join us. So questions?
David, do you know the price for the Zoom for healthcare?
You know, I've looked at it, and like so many things, there's multiple versions of it, but I wanted to say it was something around $200 per license per month. It's on the it's actually on the pricier end, a little bit on the pricier end for telehealth platforms. One thing though is that Zoom integrates with a lot of EHR systems, which is really helpful. So, which, for example, some of the like the smartphone, the more sort of smartphone based ones, Doxy.me, Doximity, Medici, their integrations are not as good. So for that ease of use, it can be worth it to spend a little more for Zoom.
Thanks. Does anybody have any questions about what David has just presented? Please feel free to unmute your phone, share your camera.
David, thank you for a lot of good information that you provided today. I'm sure that it will be helpful for everyone to choose the right platform going forward. And I think you agree that doing telehealth is not less time consuming, is not less interactive, it is not anything less except that the patient is not in front of us in the office. But it does take a lot of time to go through the process to provide the care. So for the government to say that, telehealth will be paid less compared to in-office service, I think they got to be educated on what it involves. I'm sure CMA is doing a good job. Also, next week, we have CMA Legislative Day, followed by virtual visits to all the senators and assemblymen's offices. Hopefully, at that time, we'll be able to convince them that they need to pay the right amount for the telehealth service and not just consider that as a second tier or anything like that.
It's, one of the things, I absolutely agree, Dr. Rajasekhar, and one of the things that's been hard to get the policymakers kind of focused on is that telehealth is not a service, it's a modality for providing service, right?
Mm-hmm.
So whether it's Zoom or it's the telephone or it's an in-office visit, you're getting paid based on the service you provided, not based on how you provided that service. And that's just a leap that we've struggled to get policymakers to take. That plus the fact that for some reason folks are here in Sacramento are very convinced that using the telephone for telehealth is somehow ripe for fraud, which is a red herring that unfortunately gets thrown around too much in healthcare, but it is something that has been specifically raised about telephone telehealth.
Yeah.
This is Dr. Murthy. I have a question, like even before this pandemic, like some of the psychiatry services were given via video. So that means when they paid less, then
Not necessarily. It means the plans weren't required to pay them the same. And so it, was was left up to whatever an individual provider could negotiate. But with Assembly Bill 744 and hopefully what we'll do in Medi-Cal, there will be a requirement that it will be paid the same as an in-person visit. And I agree that psych and behavioral health, because it so rarely involves putting hands on the patient, has shifted almost entirely to telehealth.
Yeah.
Sharma, I just have a comment. First of all, I appreciate your presentation. From the political aspect of getting paid for the telehealth, it'd be interesting to see if we can figure out the per visit time saved to a patient coming all the way to the office, especially for pediatrics. You know that I think it sounds a little way off, but thinking in terms of say a carbon footprint of a visit that is saved per visit for telehealth. I mean, if you put it this way, I think it'll be much more. There's no probability of fraud when we are taking this much time to make multiple phone calls to a patient and still hoping to get paid. I mean, the amount of time saved, the amount of effort saved to a patient, it's almost like getting room service, you know. You should have, in fact, we should be paid more, not if not at par for the payment. I think it's how we present it. I think it would be worthwhile. But since everybody's talking in terms of environmental impact, just the amount of silly visits saved by a small mole or a small sneeze, not having to pick up your whole bag and drive along the streets, is, I think it's a big deal.
I absolutely agree. I happen to be a Kaiser patient, and I can't tell you how many office visits it saved me. The fact that I can call the advice line or set up a time and just have my doctor call me, like, and not have to go into the office. I can't tell you how many office visits I've avoided doing that. Tomas, I see Dr. Pollock has raised her hand.
Oh, thanks. Sorry, it's so classroom for me. I wanted to follow up on how behavioral telehealth is really going to be the platform we can use for the future. But the problem I have is with the Cures Act that's just starting now, requiring that parents can have access to our charts, kids can have access to our charts. There's so much in behavioral telehealth that needs to be privatized. And so I was wondering if there's any AAP, have we figured out a form or some kind of letter that can help us be signed before we engage in behavior telehealth and other teen privacy conversations to protect us?
Okay, so it's not exactly a telehealth question, but this actually is a question I have spent a lot of time on, Dr. Pollock. And I can tell you, so what Dr. Pollock's referring to is the 21st Century Cures Act final rule, or you might know as the information blocking rule. And if you're not familiar with the information blocking rule, it takes effect on Monday. So you need to be very quickly aware of what's going on. And there are some resources that up on the CMA website about the information blocking rule. Now, importantly, Dr. Pollock, to your question, I know we're used to something happening at the federal level and it preempting state law. One of the exceptions to the information blocking rule is called the privacy exception. And it specifically allows providers, physicians, and other providers not to share information if it would violate state law. So in the case of teen reproductive health information because that is specifically protected by California law. Oh, and psych notes, because those are protected by state law. You actually are allowed not to share that information. And one of the CMA executive committee members is a pediatrician, raised this concern, and the CMA staff did a very deep dive on this to make sure we were right about this. And we have come down to the conclusion that all of the law that you operate under right now, like Health and Safety Code 123115, all of that stays in place and is not affected by the information blocking rule.
And so is there some sort of a form letter that you guys have already worked out at CMA then to that we can post, that we can have, that we can use to make this new transition easier for us to verbalize to our families who might want something?
We haven't, but it's possibly something we could do. It's a good suggestion to have some sort of, some explanation for patients who may have heard that they now have expanded access to their data, that there are certain rules under California law and that these rules still do apply. It's a good suggestion I can take back to CMA.
Excellent. And Tomas, would you be able to get that to us when it fabricates itself?
Yes,
Thank you.
absolutely. We will
We're
be
desperate. We're desperate.
anything that comes up, we will be notifying you about it, and we will host it on our webpage,
Thank you.
apca2.org/telehealth.
Great. Thank you.
Well, I want to thank everyone for your questions, and please hang on with us. David is still available to answer more questions if we have more time. Right now, we do need to move on to the second portion of our webinar, which is the presentation of a case. So we have Dr. Murthy, who's going to present her case. So I'm going to put your slide on the screen, Dr. Murthy, and you can go ahead and talk about your case.
Hi, good afternoon, everyone. This is I saw this patient, a 3-year-old Hispanic, about, I think, 2 weeks ago, with the basic symptom of diarrhea and vomiting. This mother has 2 other siblings. She's a very anxious mother. For everything, she'll call and come to the office, like any sneeze, like Dr. Sharma was saying. So we had a telehealth, and fortunately, technologically, everything went well. So I had vomiting for 2 days, up to 3 times a day, and then started having diarrhea. And one of the siblings also had the similar symptoms. So it was pretty easy, and I was able to, take the history and able to see the patient running around. So he was not lethargic or anything like that. So then I gave appropriate advice, and the visit finished. It took probably about 6 or 7 minutes, and it was done. And we did do a follow-up call to make sure she's not getting worse, and we also advised her to come back if there is any problem. So it was like, this case is like a positive side of telehealth. So can I share, Thomas?
Yes, of course.
It's not letting me share the screen.
Oh, I'm sorry. Let me just check that. Okay, go ahead and do it.
Okay, thank you.
We see yours. There it is. Perfect.
Okay, so as you know, this is the final session we are having. So all these 4 5 times we were talking about telehealth and some negative aspects. I thought let us finish with some positive aspects we have. So the positive and negative things are two sides of the same coin, and they exist. They cannot exist without the other. As some of you know, I also teach breathing and meditation techniques for stress relief, and also in that program we discuss about some of the nature of the mind, and how we can, like it's called keys to happiness. In that, one of the quote is, opposite values are complementary. That means the two the two values, they complement each other. If there is no negative and there is no positive also, there is no value for the positive. Starting with that, so this article I read in Wall Street Journal, it was on March 28th. In that, Dr. Sands, the quote is, we have learned so much about the many different things doctors can do to connect with patients in ways they never did before, that it will be hard to turn back to the clock. So like, we have done telephone, we have done video, and we have done so many other things. Now the telehealth has gone that far, so and we are comfortable with that, so it's going to be difficult to go back. Let me talk about some positive aspects from the parents and caregiver sides. Notice the first thing is convenience. They are from their home, and they are seen from home, and also in a comfortable situation. That is the first thing. It's positive on the patient side. And also time factor. Even though they're going to be seen, or the visit, in-person visit, in the not the waiting, just the examination room will be probably 5-10 minutes, but it will take about 2 hours of their time, to pack up the things and strap the babies and drag along siblings if they have nobody to take care, come and sit in the waiting room, depending upon how busy the doctor is. And then it takes that much time. So time factor is also less for them. So that is one of the positive effect. And then of course with distance learning, like this couple, they had 2 other children. One of them was in to get some child care if they had to come and visit the doctor. Can you hear me? Okay. And then transportation. Some of them don't have transportation, so that is also difficult. And the satisfaction. And it's found that, they feel so satisfied. For example, the patient I was talking, she's an anxious lady. So for everything, she has to see a doctor. So right now, she can sit at home and she can see the doctor, instead of talking to a MA. So that is satisfaction for her. For our physician side, convenience, like I know some of us are still at home and doing the practice. About 75% is done from home. So that is convenience for us. And then simple conditions like, ERI, rashes, diarrhea, vomiting, which probably forms more than 50% of our office visits, we can take care virtually. The important thing also, like for our PCP Global Quality P4P programs, one of the measure is member satisfaction survey score that has a weightage of 1.5. So it depends upon the perception of our performance by the patients, parents. Even though our performance may be good, if they perceive our performance is not good, then that's how they are going to score. So I think the telehealth will improve that score in the sense because they have access to the care, which is easier and quicker. And also other thing is, when all this, satisfaction survey started maybe 10 years ago or a little bit more, our session, like 1.5 shows the videos and then do the part play, where how as physicians with lack of time, we tend not to, spend even the some of the few minutes listening to them. We are looking at the computer screen, or we are looking at the charts, the paper charts, and we forget to that connecting with them is eye to eye, even if it is like 3 minutes, 4 minutes. If you completely pay attention for that 3 4 minutes, they feel satisfied. That means, okay, the doctor is listening to me. So I think that part is taken because we have 100% attention on the video screen. So they also have the same that 100% effort, because sometimes they come to the office, when we walk in, they are still on the phone finishing up a call or texting. So there also, now they also have 100%, so that satisfaction happens. So that will definitely increase the score, I think. And then of course finance, when everything was closed for almost 4 or 5 weeks, if we didn't have the telehealth, I think financially, even though we have lost, but it would have been worse than what it is right now. And then the same article in Wall Street Journal, they've said like that the estimate was 20 to 25% will be still be happening remotely after this post-COVID. But at Stanford Health, they found that even though resumed the in-person, more than 30 to 40% still want the virtual. And then about third of the new patients, who had done only virtual for the first time, they would prefer to do the video consult over the in-person. So that is how the survey shows. So that means the patients are also getting comfortable and feeling better with that. And Dr. Sharp says it is not surprising that this was better than nothing, but what is surprising is how highly virtual care is valued by our patients. So remember the perception of the patients. If they think it's valuable, then our score will be high also. And I thank you for the AAP Chapter 2, especially Dr. Rajashekar so much, and Chris, those who are behind the scenes helping, and for all the experts who really, educated us, in this field, which we are not used to, especially people like uh, me and Dr. Rajashekar, who are all probably, with gray hair, with stimulating and motivating us to learn new things and go forward. Thank you so much.
Does anybody have any questions at all about what was spoken today, including the presentation from David Ford? We still have 10 minutes if anybody has any questions or concerns about what David presented or what Dr. Murthy presented.
Just one comment regarding this CARES Act and patients getting access to the records from doctors' offices. This CARES Act has been there for it was passed some time ago, but this particular aspect of patient access to medical records was not talked about much until recently. I got a few emails from different places regarding this. It is going to cause a little bit of a problem until it is addressed by our CMA pretty soon. Please pay attention to that, because this will become medical legal. The patient comes and says, hey, I want to look at my record as soon as you finish writing or whatever, and you say, no, I can't share everything. There's a problem because, for example, for pediatricians, neonatologists and all, when we talk to the mother, we talk about history regarding what happened during pregnancy, how whether mother was healthy, using drugs, this, that, and all. We talk to them and we document those things in the chart. This becomes like a two-patient chart. It is not just a pediatric patient, but also the mother's information is there. So now we are sharing mother's information. The father of the child doesn't know a few details about the mother, what we recorded already in the chart. That can bring up some other problems between the father and the mother. So it has got a lot of interlinked things, whatever we documented all these years to help patient care. If it becomes public information or a family information, not necessarily public to everyone, but even within the family, there are certain things which are not shared by members, that can cause problems. So we need to be careful about, until this problem is fixed, we need to be careful about what we document also. Unless it is really, really necessary for patient care, in an indirect way, maybe we need to document them in a way that we are doing today. That's all I got to say. So CARES Act, please remember that.
Yeah, Tomas, it sounds like we may need to have another conversation set up about information blocking, because it's a whole topic unto itself. Dr. Rajasekhar, I would only say, in the situation that you described there, there is a patient harm exception. So to the information blocking rule. So in the instance that you described, where you may have two parents who are estranged, and maybe there's been a divorce, one doesn't know what's going on with the other one, all that sort of mess that happens. You would be able, as a physician, to not share that data, and if it were challenged, say, I am not sharing this out of a concern for patient safety under the harm exception. So that's really the important part. I tend to think actually the information blocking rule will be more beneficial than it will be a burden for physicians, because a lot of the data that you today don't have access to, you will. And a lot of the things that have really hampered physicians from having access to that data, like when your EHR companies ask you to, for outrageous amounts of money for building interfaces to labs, to health information exchanges, all those sort of things, that all becomes information blocking starting Monday. And I think for physicians, probably not as much is going to change as you think, because you are still protected by California state law under the rule. So yeah, as I say, that could be that's a whole separate conversation, and I could spend, trust me, well more than an hour just talking information blocking.
That's what I was meant to say. So we now need to learn one more thing called information blocking, and pay some time and attention when the records are looked at by the patients. So we need to pay an addition. We need to first of all learn what we are allowed to block and not, because you don't want to block something that is not allowed to be blocked, and then you can get sued for not letting them see that. Or you let everything go out, then you can get sued for letting everything go out. So it's another learning process over a period of time, and I'm sure some physicians will get hurt in the process in the meantime.
So, David, if this is coming up soon, will there be sort of like a fact sheet or something produced that physicians will be able to look at to get the scoop?
Yeah, and I'm putting a couple. Where did it go? I'm putting a couple of
I see the link on
Yeah, I'm putting a couple links in the, trying to
Dave,
find the other one, because there's a webinar that CMA did with um, with the Office of the National Coordinator for Health IT. We did back about a month ago, but we also just published a here we go. I found it. We just published an FAQ that we will be adding to over time on the information blocking rule that also links. So our FAQ has some of the questions we've heard from physicians, but also links out to some really good stuff that the AMA has done on the information blocking rule. So there's just a couple resources specific to that that are available to you.
Great. Thank you so much. So David put those two links in the chat, but we're also going to have them on our webpage, just so that everybody knows. Well, thanks everyone. If you notice also in the chat, Chris put in the link for the evaluation for this event. We need at least one of your evaluations for CME purposes. So if you have never completed our evaluation form, which contains a check form that you indicate which sessions you attended, uh, we need at least one of those completed. And then ideally, if you would answer the specific one for each session, that allows us to know how you felt about the speakers. So thank you so much for taking care of the evaluation as well. And to wrap it up, I want to let everybody know that the CME takes about a week to be completed with PeerPoint. We look at our attendance, and then we submit the attendance spreadsheet to PeerPoint, and they take about a week to process everything and post your CME certificates online. Everything, if you have not attended our symposium in the past, we work with a company called PeerPoint, and all CME certificates are electronically accessible on a PeerPoint website. You log in with your user ID is your email address, your password is your first name, and then you have to complete a very brief, it's like 3 questions. Question it's sort of like an evaluation. It only asked 3 questions about the event in general, and then after that you can designate how many CMEs you are claiming because of the fact that we are a series. So it'll be from 1 to 6, and it'll be in an honor base, pretty much. So we do have the attendance, but you can always designate how many hours of CME you are claiming, and then for MOC Part 2, that's going to take another week as well. There will be a takeaway points or pearls document with the highlights of all the sessions to look at as reference. And then there will be an exercise document required by the American Board of Pediatrics for all of you who do look for MOC Part 2. And we are past the hour. I want to thank everyone for participating in all of our sessions. I want to thank all of our speakers, and I want to thank David Ford for always being a strong player in our sessions. And thank you to the CMA. Thank you to the San Bernardino County Medical Society and our participants for being with us throughout this time. Thank you so much. And have a great day and rest of the afternoon. Thank you.
thank you all. Bye.
Thank you.
Thank you so much.
Thank you.